let's move on to the next session. To chair the session on the topic intradialytic nutrition, tools and techniques, I'd like to invite the chairpersons, Dr. Krishnan Patil sir, Senior Consultant Nephrologist, Apollo Hospital, Nanakramguda, Hyderabad, Dr. Priyadarshini John ma'am, Assistant Professor, Usmania General Hospital, Hyderabad, then Dr. Susmita ma'am, Senior Consultant Nephrologist, KIMS Hospital, Hyderabad.
So the speaker for this session, Dr. Nisha Jose. She is the Associate Professor at Christian Medical College, Vellore. She is a gold medalist in DM Nephrology from SRMC, Chennai, winner of SWIMS essay in nephrology, twice speaker in multiple national and international nephrology programs, and curation of academic content in department nephrology programs. She has more than 25 national and international journal reviews and publications. Over to you, madam.
So thank you to the organizers for having me here. So we'll jump straight into the topic, intradialytic nutrition, tools and techniques. So this is going to be a little bit of a practical application based session. So the learning goals are, we're going to start with how to evaluate very briefly what is a step ladder pattern to treatment, what is there in our armamentarium to treat patients, and then we're going to holistically look at medical nutrition therapy. So I'm going to put up a picture and I hope you all will look at it and tell me who do you think is unhealthy. So you don't have to worry, these are not real people, these are AI generated images, and I think maybe about 10 years ago our dialysis population used to look like the man, like the skeleton man, and now we sort of have a mixture of people. We have some people who are emaciated and some people who are overweight or obese, but it is important to know that just because somebody is obese, it doesn't mean they are not malnourished. There is a section of people who have what is called as obese sarcopenia. So this is very common in the kidney disease population, where the muscle mass is actually less, and they suffer from all the things that come with malnutrition, like for example maybe some illnesses, frequent infections, generally feeling unhealthy, being fatigued, poor memory, everything is there. So I'm going to bring you back to a very real world scenario. It's a patient who you and I have seen many times over again. This is a 32-year-old male auto driver. He has 2 school-going children and a wife at home who's a homemaker. He is a CKD patient who's been on dialysis for the last 6 years through a BCF. He's on twice weekly dialysis. He has no major comorbidities. Of note, his BMI is 17.8 and albumin is 3.1. He's had a lot of progressive weight loss over the last 1 year. So the question I want to ask all of you is, when you see him, the next thing that should be coming into your head is what is actually happening to this man. So this man is an auto driver, so he has to ferry people from one place to another. He's skipping his meals very frequently. He eats poorly. He has to support his 2 kids and his wife. So you can imagine that that protein of 1 to 1.2 gram per kg is not something that's going to be easy for him to get. He will fit very well with ISRNM diagnostic criteria because he's got an albumin of 3.1, his BMI is 17, and I told you that his dietary intake is very poor. So let us say that he has PEW. Now the next question I want to ask all of you is, what do you think we can do to help? Do you think we should give him more advice? Several people have actually given him a lot of advice. Do you want to increase his dialysis? Do you want to give him some advice about food quality? This is all something that we deal with every day, right? Or do you want to start him on some supplements and send him on his way? So to address this problem, you need to know what the causes are. I'm not going to go into very much detail, but all I want to say is that I gave you some things. I told you that his food intake was not good, but that's not the end of the equation. For somebody on dialysis, several things come into play. Inflammation, is the dialysis removing too much protein? Is there a lot of catabolism? Are the infections eating away at his protein? So several things work together. The answer is not very simple. To approach this problem, usually the best way to go about it is what we call a step ladder approach. That means you start off with regular healthy diet, then you move into protein rich energy snacks, then you escalate a little more to oral nutrition supplements, and then of course last is IV. So when you say regular healthy food, what do you mean? I'm sure I should not be preaching to the choir, a whole bunch of nephrologists and dietitians in the crowd. So I'm just going to say that when we prescribe a renal diet to people, Sometimes, like for example, the two patients that I showed you, the emaciated man needs more calories. You can actually prescribe him more carbs. But the obese sarcopenic patient, you will have to cut down on the carbs. So you need to individualize this prescription. Suppose a very thin man was not able to eat because the sambar that was being made in the home had too little bit salt. That may actually be contributing to his malnutrition. So there is a role of personalizing the prescription. Keep the guidelines in the back, but remember that people are different and you need to tailor your prescription to the patient. Now a very controversial topic about eating during dialysis. I am sure if I take an opinion poll of this room, there will be quite a mixed answer on what you all feel. Just to put things into perspective, I look at the history. So when dialysis first started, actually people were routinely being fed during the dialysis session. So this is a picture of a lady in France, in Tassin, where these things were started, where there was a lot of like 12 hours of dialysis initially, and people were being given, she's enjoying a blob of cheese actually during her dialysis session. So they were actually given things which they enjoy eating, which on an otherwise normal day, people would say don't eat so much salt, don't eat so many lipid containing saturated things. So these things were being done, people actually enjoyed dialysis. There's certain something when you're given food, you feel a little cared for, like your mother made it. So now what has happened over the last few years is the dialysis sessions have become shorter, and we need to worry about what we're giving the patient. We can't just give anything to the patient, we prefer to give high quality food. There are logistic concerns, and I think the thing that concerns most of us sitting in this room is we're always worried, is the patient going to hypotense? So to address that, there was a paper that was put out a few years ago, 2017, which talked about this very important concern. So I have taken this figure from that paper. What you can see here is actually on this side the dialysis treatment has been started, right? And then after the dialysis treatment has been started, the meal was given, that is where the blue line is. A few hours after that, hypotension started because a lot of blood was shuttled off into the mesentery to help digest the food. Now according to this paper, suppose you gave some caffeine, maybe you would be able to offset this. And I want to very importantly say that not everybody who is fed during dialysis is actually going to hypotense. A few people do. Some people also develop some pain like cramps in the stomach during dialysis if you do give food, but this is not everybody's story. So suppose I told you that the auto driver man was being given 2 eggs by a very caring dialysis nurse, and I told you that he didn't have cramps and there was no hypotension, maybe that would be an excellent way to bring up his nutrition over time. So you need to individualize this therapy. Somebody who is tolerating it well, please continue giving food during dialysis. It's an excellent measure because you can watch what the patient is eating. The next step, one step higher on the ladder, is oral nutrition supplements. So these come in various forms. There are pills available, then there are powders, there are biscuits, there are several snacks, protein-rich snacks. Now each of them will have a different protein content. Most important, what we need to remember for the kidney disease population is that you can't use a generic sort of food or a snack because they may contain a lot of potassium, they may contain a lot of phosphates, they may have a lot of preservatives. So you need to look for something that is very renal specific, and also each of these supplements will have different quantities. For example, the pill may have just 1 gram, each scoop of a protein powder may have 10 grams. So this needs to be sort of individualized. It's important to remember it's a supplement. So this should not be the entire protein content. It should be an add-on therapy in someone not meeting the protein requirement. Just like we talked about food during dialysis, same with oral nutrition supplements, the same things can happen, hypotension, poor tolerability, but choosing the right patient, and if you give it in the proper way, it will definitely benefit the patient. So this is the second step. So we talked about regular healthy food, then we talked about nutritional supplements, and now I'm moving to step 3 of the ladder, intradialytic parenteral nutrition. So enteral nutrition is always preferred, but in somebody who is not tolerating oral food very well for whatever reason, or is not doing well on oral therapy, you can definitely use intradialytic parenteral nutrition. It is easily available as ready to use bags are there. You can also customize the bag. So usually it comes as a 1 liter bag. Now what is the content of this bag? It is usually calories around 500 to 800 kilocalories that will come in the entire 1 liter. Protein will be about 30 to 60 gram, and there will be some amount of fat and glucose. Generally, the micro elements are kept to a very minimum, and usually vitamins and minerals are not part of it, but different bags will tell you different things. So, where is it connected in the circuit? It is connected after the dialyzer and before the air trap. So, you can imagine that during dialysis a little bit will be lost, but it is usually not much, usually 80% of it actually reaches the patient. Now, the important question is, because these therapies are very costly, like who do you want to give it to? So, that is actually answered by someone who is not tolerating an oral supplement or an enteral nutrition very well, or somebody says planned for a major gastric surgery for some reason cannot take, or you are expecting that patient to develop malnutrition over time and you cannot feed that patient. That is the person who will benefit from this. Generally, we start at 125 ml per hour during dialysis. So, it is only given during the dialysis session. So, maybe 1 liter will go after you have reached the optimum dose of 250 ml per hour in the second week. Very importantly, so it is containing around 800 kilocalories. So, that is like 3 slices of a cheesy Domino's pizza going in one shot. So, after you have this sort of a meal during dialysis, a lot of the time patients will not be hungry. So, sometimes it may curb their appetite a bit. Also, it is quite costly, there is a risk of contamination, and because it is a very high calorie content at one shot, it is very unphysiological. So, sometimes what we find is that there may be some reactive or hypoglycemia that happens towards the end of the session. You can easily counteract it by giving a rich carbohydrate rich meal to the patient. So, another aspect of IV therapy is an amino acid infusion. These are slightly cheaper, somewhere between 700 to 900 per bottle, 1.1% amino acid solutions. They are mainly containing amino acids, so protein. It is not like the parenteral nutrition which has lipids and carbohydrates, but definitely add on supplement, it will definitely increase the protein. Now, we talked about 3 steps of the ladder. Now, we are going on to the 4th step, exercise as a tool to improve nutrition. So, like all of us sitting here after we had a heavy lunch that the organizers have been very generous with us to provide, we are probably feeling fatigued, and maybe your exercise tolerance tomorrow is probably going to be less. So, the best way to actually improve nutrition is to combine it with good exercise practice, and it is very important to find the right balance. So, when you are looking at kidney disease patients, they may not be able to tolerate anything. You are not looking at a very baseline healthy population. Like you may find somebody who is having heart disease, somebody who has just taken some OHA medicine, somebody who has just taken as antihypertensive, we may not be able to exercise very well. It is very important to individualize the prescription and slowly increase the exercise as the patient does better. This should be part of a general rehabilitation program as part of getting the patient well. The step 5 is dialysis and diet. They always go hand in hand in any dialysis patient. So, we always like to have our KT/V targets 1.2 to 1.4 per session in hemodialysis, 1.7 in PD. Going above this generally does not help the patient. If your patient is not volume overloaded, the KT/V targets are met, there is no electrolyte imbalance, it is unlikely that going on increasing the dialysis in this patient is going to benefit. If your patient has not met these targets, then you probably have to look at whether his dialysis needs to be improved. This is just something interesting that I came across when I was looking at dialysis and nutrition. I used to think that HDF is a modality where a lot of albumin or protein is going to be lost through the membrane. But what was actually shown in one particular study that looked at it, which came out in KRCP, was that over time albumin is actually better in patients on HDF because a lot of inflammation is actually reduced. But I want to tell you that this is just one study, and this is a relatively new area and an emerging concept. PD patients also need our special attention, a lot of protein being lost during each day for a PD patient. The last step is pharmacological interventions. I am sure you all would have come across several of these names easily prescribed when your patient is not doing well. Maybe megestrol acetate, cyproheptadine, some other hormones as well are known to actually improve muscle mass, nandrolene, anti-inflammatory agents, anti-cytokines, IL-6, lot of drugs are there. Of note, I think mainly they have been shown to improve weight. Some of them do improve muscle mass, but we do not have any hard outcomes really improving due to these medicines. They are generally used as add-on therapy, and you should not be prescribing it thinking that this is a one-stop to improve the nutrition of a patient. So, what actually happened to our patient? He was given oral nutrition supplements because he had already received a lot of dietary advice. He had some response. His diet was also improved. We gave him IDPN, his weight stabilized, and along with some exercise, he showed functional improvement as well. So the key takeaways, what I want you to remember is what will you do on Monday? When you go back home, identify patients early. Don't stop at dietary advice. Use a ladder approach. Combine various techniques, food, supplements, dialysis optimization and exercise. If one step fails, remember to escalate. Thank you.